Are you tired?
No, no.
Good.
I,
Shall we do a letter together?
yeah.
Um, let's have a look at that.
Oh, it's my letter.
Okay, it's a Mr. Elvin. Let's see. Okay, how many words do you have here? 277. Good. Quite a lot. Okay.
Is this kind of case note is very problematic for me because the patient has mm, several consultation meeting, and all of this is relevant to the condition, to his or her condition, and I cannot choose or select two or three out of whole of them, and for this reason it's difficult for me to write in this.
Okay. So this patient is, yeah, obviously, most of the tasks are the same. Okay. There are several different criteria, entries, and you have to summarize that. So, how many words are we asked to write?
I think that is better a range from 180 to 200.
Okay, so that's the guidance. Now, let me tell you something. Uh, um, it is just a guidance, okay?
Yeah.
So if you write more or less, it doesn't matter. What is counted? This is clearly what the answer I received from OET. It said, "Does the word count matter?" And they said, "Words are not important,
Oh,
uh, but the information is checked." Okay, so the content that is necessary is counted basically. But also, I was told that uh, if you have a standard case note which is prepared by OET, the best letter that you write with all the content and efficiently and effectively summarized and basically a perfect letter would be between 180 to 200 words.
yeah.
Okay?
Yes.
Right. Tell me about this patient. Um, Let me find. Where did you get it from? Benchmark, yeah?
In different groups because I'm struggling with finding case note, and I joined the two different groups, and I think that this is in the Persian doctors OET group. I found this case note.
Okay. Let's have a look. Um, okay, tell me, what is the story of this gentleman? Who is writing to whom?
Uh, oh. I think that I'm getting old, and no, I am suffering from dementia. It's a patient. I think that is we are referring to registrar, and she is suffering from the mild asthma and the chest pain. And in
Okay, so how old is the patient?
uh, 49, 48.
Okay,
Something.
you can check the case notes if you want.
Yes, yes. I'm trying to find and open this. This patient, 48.
Okay. I'm the registrar. You're introducing this patient to me. You have a 48-year-old, okay, and man or woman?
Man. No, no,
You
no, no.
have,
No, 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 man. Sorry.
okay, 40 years old and it's a man, and okay. Uh, so you're talking to me. You want me to see these patients. What do you say?
For further treatment.
What is the problem? You're calling the
Uh, because uh, sudden onset crushing chest pain with worsening of asthma, and he transferred to from a medical center with complaint of sudden onset of crushing chest pain with worsening of asthma. And
okay. So um, you are the GP in health center. I am the registrar. You
yes,
call me, say hello. I say hello. Yes, doctor. This is Robert, the registrar. How can I help you?
hi, I try to transfer my patients. Is a 48 man, and she has she has a history of mild asthma from childhood, and in over now now he has a worsening the asthma signs, asthmatic symptoms, and associated with the chest pain. And in EKG, we found that ST elevation in anterior leads, and on
So
examination,
okay. So the patient has an MI.
yes.
Okay. So what is it to do with childhood asthma?
Because associated with these symptoms, we can find bilateral wheeze and crackle on auscultation.
Okay. No, excuse me. If you call the emergency department and you say, I'm going to send you a patient, and they say, okay, what's wrong? What is the problem? Do you
Oh,
say he has had childhood asthma?
no, 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 no.
What do you say?
Only it's better I see that the patient the patient had a sudden onset of crushing chest pain, and after that the EKG show us a ST elevation.
No, no, you don't need to say those now. When you call someone, when you want to introduce a patient, okay, suppose it's a morning report, okay?
Yeah.
In a morning report, you want to introduce a patient. What do you say? We have a 48-year-old man with sudden onset chest pain and possible MI.
Oh, yes.
You don't talk about childhood asthma here because asthma is not important.
Yes, I know. Yes, yes, exactly.
Okay. Are we admitting the patient because of asthma or
No,
childhood asthma? No.
no, no.
So why are we admitting the patient?
For the MI,
Okay.
the recent MI.
So you're referring, so you have a patient, 40-year-old man, okay, uh, a 48-year-old man with sudden onset chest pain
Yeah.
and uh, possibly MI because of the ST elevation. Okay,
Yes.
right. Okay. Now, this is what we want basically. What we do, the first thing we do is this. Okay, we go to the last entry. Okay,
Yes.
So now, what is the essential information? Now, tell me, what is the next thing you explain to the registrar? You start to say how it happened, okay? Tell me, okay, could you tell me more how you found out he has MI?
Uh, the first thing I said that about the subjective, and now is about objective, maybe on examination.
No, 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 no. Just tell me the history of the presentation, okay? How the patient came to see you and how you found out it is possible MI.
The patient in the street transfer from a medical center. The first going to medical center, and after that transfer from medical center to me, my clinic.
Okay, so he went to medical center. When?
When after going to my clinic, I try to doing some a set of investigations, such as
Uh,
EKG.
Excuse me to interrupt you. Just tell me the story. When did he go to medical center?
Today.
Okay, so went to medical center today, and then how long ago was that?
Uh,
This patient has an MI. I want to know when he had MI.
oh, don't mention in the case note.
Okay, so went to medical center today, then transferred uh, to me. Okay, and when he arrived, what did he tell you?
Uh, in case note, there is no more information about this.
Doesn't it say when the pain started, how it started?
No, no, no,
Nothing. Okay.
not. Yeah.
Usually they say, okay. Now, so you have a patient now. He has sudden onset chest pain, and he has possibly MI. Went to medical center today, then transferred to me. Now we don't have any other history. No, okay. This is so. Does he talk to you? Is he saying anything?
Uh,
We don't know.
no, no. In the case note, don't say about more this. Uh,
Okay. He was passing by a medical center and complained of sudden onset crushing chest pain on background of URTI and worsening asthma since last what? Okay, not relieved by anginin. Okay, so is this yeah, probably significant? ECG mild ST elevation in anterior leads. What is ST 120?
uh, I don't know. It's maybe the ST segments.
Okay, I don't know. Lungs, moderate wheeze, mild bilateral crackles, SpO2 86% on air. Hearts, slight S3 sound positive. Okay.
And sorry, I don't know about the OA and RA. The abbreviation of OA and RA, I cannot find it.
Uh, these are not,
Important.
yes, they are important, but these are not standard uh, abbreviations.
Oh,
Uh, OA means on auscultation, okay?
oh,
And this means on uh, air, I think, or respiratory aid or air, I don't know. These are not what we normally use.
yes.
And mild APO, we don't know what APO is. We don't usually use that. ED, yes, emergency department, and GTN, yes. So, uh, basically, if we have any history, we say that. Um, If not, then we just leave it. So he was passing by the medical center. It doesn't say anything about transfer. He was passing by.
Yes.
Okay.
I
So
think that passing maybe means of transfer.
no. Passing by. It was just passing next to the.
Oh.
Okay, passing by. Passing by medical center today. Then so had crushing chest pain. Had sudden onset crushing chest pain. Okay. And then on examination, you said that. On examination, he had what? Wheezing. Uh, and what else?
Crackle.
And crackles. Okay. And that chest pain that did not.
And S3 in auscultation.
Okay. That chest pain did not respond to angenin. Okay. On examination, wheezing and crackles. S3 positive. And
That's it.
okay. Right. SpO2 is 86%. Is that significant?
Yes. Yes, significant, but
Okay.
I didn't
Right. Okay. If you don't know the abbreviation, just write it. Okay.
Yes. I
Mm, okay. And then what did you do? And then ECG. Okay.
yes.
ECG shows ST elevation
Yes.
in anterior lids.
Yes, exactly.
Okay. And then what did I do? My
Uh,
assessment.
um, I did O2 oxygen via
Uh, look,
repressor,
assessment
not
first.
repressor.
Assessment.
Assessment. No, that's
Yes.
no, no.
So with impression of anterior MI, what did we do?
O2 via non-repressor, not,
Okay.
not nitroglycerin, morphine, ipratropium, and furosemide.
Mhm. Okay. And with impression of anterior MI, possibly in the background of asthma and URTI. Okay. So with this impression, he was started on O2. Now, how much it is, and then what?
And is 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 total information. O2
This whole thing.
nitroglycerin.
Okay, and the rest. Okay. So now we go back and see. These are the essential information. Yep.
Yes.
Okay. And this is mild asthma. And this goes to okay. Offered ETOH. What is that?
I don't know.
Ethyl alcohol as ethanol.
Oh,
Okay. So these are the good to know information. Okay. Now, um, but it's not relevant to the MI. Do you agree?
yes, completely.
Mhm. So what is the date today?
Date today, I think that
1st of June
first.
2011, okay?
Yes, yes.
And this is 5th of May. So I've seen him 5th of May, but what was that for? Central chest pain. And he smokes this much under stress, serotype, salbutamol, and troponin normal. Okay, so he had some chest pain a month ago, but his troponin was negative. Okay, so there was no MI. And then again, I saw him 2 more times, once on 12th of May, once 26th of May. Okay, and on 12th of May, what did I do?
His chest pain on exertion is important, but about a runny nose or pharyngitis is not main problem.
Mhm.
And investigation is better to mention about the stress test and how to find this during this test.
Mhm.
And I think that is better to say about the slight ischemic change or etc.
Okay, so the first time that he had chest pain was a month ago. Okay, now a month ago attended with mild chest pain. Troponin was negative. Okay,
Yes.
and then came again. And was there anything else that uh, had chest pain on exertion? Okay,
Yes.
and then an exercise test
Show ischemic change.
showed ischemic heart disease, and he was started on in medications. Okay,
Yes.
agree?
Yes. And lab test shows that high level cholesterol.
Okay, okay. So lab tests uh, showed high cholesterol, and exercise test showed ischemic heart disease. So we started him on some medications. Okay. Mm, then these medicines started. Okay. And now, chest pain for the last week. Still complains of frequent mild wheeze. Often forgets to take serotype puffs because of ethanol consumption. Okay. So, uh, compliance with medications, alcohol dependence. Okay. So these are now good to know information. So we say uh, alcohol dependence, non-compliance with medications. Okay.
And smoker.
And smoking. Okay. What else?
Uh, there is no important for mentioning about the asthma and upper respiratory infection recently or UTI.
Yes, we say here he's got asthma since childhood, and he takes serotype but non-compliant. Okay, and after all of these, okay, we say Um, no allergies, nothing else?
No.
Okay, right. So now we have a picture. We have a better picture. And the paramedic transfer. Basically, we say uh, paramedic transfer to emergency department. Okay. Now, okay. So, what did I do here?
Um, I think that is a emergency refrigerator, uh,
Yes.
and someone others maybe said that in the emergency refrigerator is better starting with the chief complaint and the recently visited, and I don't know is a right way or not.
Okay. You see, if this case comes to me, I'm sitting in the surgery. The first thing I do after I know that he's got an MI, the first thing is I put oxygen for him. I put IV access. I give him um, a GTN patch. I give him um some morphine, maybe clopidogrel and uh, what is the other one? Atorvastatin,
Yeah.
80 milligrams of Lipitor. Um, okay. And if he's wheezing because he's got asthma, maybe I give him some nebulizer for apratropium. Okay. I don't want to make him too tachycardic with salbutamol. Okay.
Yeah.
And the next thing I do, I call the registrar in the emergency department and I say, look, I have a 48-year-old man with sudden onset chest pain, and the ECG shows he probably has an anterior MI, and I'm going to send him to you. Okay?
Yeah.
I said, all right. Could you tell me what the symptoms are? Because the registrars don't like patients. They say, well, tell me uh, how you how you know that he's got an MI. I said, well, basically he came, he was just passing by, and he had this severe crushing chest pain that didn't respond to angionin. I did an ECG. The examination showed wheezing, crackles, S3, and SpO2 was 86%. Uh, we did an ECG which shows ST elevation. Because he has had chest pain since a month ago, uh, but he is not compliant with medications. I think he hasn't had his medicines, and that's why he's got this MI. And okay, any background information? Yes. He has asthma and he's had upper respiratory infection. He's alcoholic. He drinks a lot of alcohol, or he's dependent on alcohol, and he smokes 20 cigarettes a day. Um, and basically, this is the background. Now, okay, what have you done for him? Well, I gave him oxygen and morphine, GTM patch, nebulizer, and I have arranged for an ambulance to transfer uh, by paramedic. Okay, what would you like me to do? Please uh, admit him as an emergency, or please see him urgently because this is MI.
Yeah.
Okay,
Yes.
so that is how you introduce this patient. Now, uh, the other information is irrelevant information.
Yeah. It's a
Okay,
new vision. Yeah, it's a new vision for me. Thank you so much.
so uh, let's read yours.
Horrible.